Everyone. Uh, my name is Peter Nigrovich. I'm a pediatric and adult rheumatologist at Boston Children's Hospital and the Brigham and Women's Hospital. And my co-moderator here is Dr. Sean, a third-year pediatric rheumatology fellow, physician scientist training program at the University of Minnesota. We are your moderators today of the VIP program, the Virtual Rheumatology Practicum in Pediatrics. And we're very happy to present today a talk by Dr. Grant Schulert entitled Systemic Inflammation in Children, Systemic JIA, Macrophage Activation, and COVID-associated MISC, all very important topics. Grant Schulert is someone known probably to many or most of you. He's an assistant professor of pediatrics in Cincinnati. He received his MD and PhD from the University of Iowa, Carver College of Medicine. He then completed chief residency at Vanderbilt before doing pediatric rheumatology fellowship in Cincinnati, where he remained on his faculty and runs a laboratory. He's well known for his work in systemic JA, in its lung disease, and in MAS, and he directs Cincinnati's Autoinflammatory Diseases Treatment and Research Center. So we're looking forward to his talk. Some ground rules before we start. They're displayed on the slide in front of you. So all attendees are muted throughout the webinar. Questions will be done at the end via the Q&A function at the bottom. So Sean and I will be monitoring the questions as they're submitted and present them at the end. Please use the chat function at the bottom to make general comments that everyone can see. There is a raise your hand function to run into technical troubles, and that will be those messages will go to the ACR staff, who can send you a private chat to respond to any technical problems. And again, importantly, we want to make this an interactive discussion. The talk's about 45 minutes, so we'll have some time for questions and can bleed a little bit over the hour if we need to. So please use the Q&A for that function. All right, so without any further steps, Grant, thanks for agreeing to give this talk.
No problem. Thank you, Peter, for that introduction. Let's see, here we go. All right, so I was joking earlier that I'm giving 3 talks that could each be about an hour in about 45 minutes. We are gonna really focus on some broad points in sort of all of these areas, but certainly happy to explore areas of interest more at the end with questions. Here are my quick disclosures. And sort of 3 objectives that I think will sort of direct where I'm going to be discussing in each of these 3 areas that all sort of, the shared feature I think is really systemic inflammation, and you could even say folks with fever who they call rheumatology for. So my objectives, as you can see here on the screen, are first to discuss some of the clinical and pathological features of systemic JIA that distinguish it from the other subtypes of JIA, who you heard from Dr. Weiss, and you'll be hearing about more in future ones in this series. And then transitioning to MAS and talking about recognizing some of the clinical and laboratory features that should make you worried about MAS, particularly in the setting of systemic JIA. And finally, spending the last 15 or so minutes of my talk talking about a very recently recognized entity, MISC, associated with SARS-CoV-2. So, starting with history, I'm sort of a history buff and like, remembering some of the stories about how these diseases, our understanding of these diseases evolved over time. So what we now call systemic JIA was first recognized by sort of one of the great historical pediatricians, Sir George Frederick Stills, at Great Ormond Street. He was England's first professor of childhood medicine, and amongst other things that he described was the first to describe attention deficit hyperactivity disorder. But in 1897, he described a series of 22 children with what we now call systemic JIA. And for a long time, those were called by the acronym of Still's disease. And of course, we still call the adult flavor of this disease adult onset Still's disease. Over the years, then, it's been called many things: systemic onset juvenile chronic arthritis, systemic onset juvenile rheumatoid arthritis. But then with the advent of the ILAR JIA classification, it has since been classified as systemic JIA. So the classification of that within the JIA system is relatively straightforward, right? So all of the JIA, strictly speaking, require chronic arthritis lasting at least 6 weeks or more. Although I will note that we don't typically wait for 6 weeks of symptoms with systemic JIA before initiating treatment. Diagnosed in children before the age of 16. And then a requirement for daily fevers for at least 2 weeks, including at least 3 days of this quotidian fever that we'll talk a bit about more in a second, along with arthritis, as I noted, and one or more of the classic systemic symptoms of this disease, the evanescent rash, adenopathy, hepatomegaly or splenomegaly, or serositis. So as I said, this is currently considered as a subtype of JIA. JIA, as Dr. Weiss described, is really a collection of disorders that share the features of chronic arthritis that present in childhood. But really all of these are very distinct and unique diseases. And I think by pulling out several of them for their own talks, I think we hope in this series to highlight that they're very different diseases. A few notable things within systemic JIA that differentiate it from some of the other forms of JIA. It has sort of a broad peak of onset. This table says ages of around 2 as the peak, but really a sort of a broad peak up until about age 10. There's very little of a sex predilection in systemic JIA, maybe a slight female predominance, but very slight compared to the oligo and polyarticular forms of JIA. Rarely are there positive autoantibodies. Our presence of RF is strictly an exclusion in the ILAR criteria. Most of them are ANA negative. Most of them are B27 negative. There's a relatively low risk of arthritis, and systemics are automatically in that low risk in the uveitis screening. There is typically not enthesitis or dactylitis, and then those high spiking fevers that I mentioned. So arthritis, right? So it's right there in the name. So arthritis has to be a prominent feature of the disease. However, it can be very, very variable, as you see here. For many patients, close to certainly a third, maybe up to a half, there can be sort of a polyarticular presentation with multiple joints. These can be small joints, medium and large joints, really sort of any kind of a pattern. For another chunk, there can be sort of an oligoarticular with just a couple of joints, which in my experience is usually larger joints. Occasionally you'll find just a single joint that's positive. But in something around 10% of patients, at the onset, there is no arthritis that's detected. And, from the more historical cohorts, when we watch these patients without treatment, many of those patients over the course of the first 6 months of disease would manifest some arthritis. But some patients, 5 to 10% certainly, would really never have arthritis. In these patients, the diagnosis is very difficult, and strictly speaking, they wouldn't satisfy the ILAR criteria, which is one of the onuses for sort of some reconsideration of the ILAR criteria moving forward. I would also note that in adult Still's disease, arthritis or even arthralgia is not a strict criteria for the diagnosis. It's certainly one of the criteria, but it's not strictly required for adult onset Still's disease. The fever, as I noted, typically these patients have a persistent daily fever. It can be sort of, if it's been gone on for weeks and weeks, there can sometimes be a couple days of skipping and then a return of the fever. But then there's at least several days where there's this classic quotidian fever. And again, we all remember from our general peds exams that that's sort of one of those magic words that when you see they're talking about systemic JIA. So you'll see this spike of a fever once or twice a day, generally in the late afternoon, sometimes in the morning as well. And it's very, very regular. Patients will say, every day right around dinner time, little Johnny would spike his fever. And you can see this here in this graph where there's this sort of recurrent spike here at around 2000 hours every day, like clockwork. The rashes of systemic JIA, The one on the left is from the Cincinnati archive. The one in the middle was taken by Jess Tournier, one of our former fellows who's now faculty in Michigan. The one on the right is from the ACR Image Bank. Again, classically described as this evanescent, again, another magic word on the general peds exams, which means coming and going, salmon and coloring. This very striking Kobler phenomenon that you see on the right. So often in those sort of the armpits, areas of contact, and worsens during the fever itself. Sometimes there can be some rashes that are more urticarial-like, which can happen as well. But again, typically will come and go quite quickly and be more prominent with the fever. So what about lab tests in systemic JIA? Again, as with all of the forms of JIA, there are no tests that really diagnoses or rules out JIA. But you sort of see patterns that really reflect the significant systemic inflammation. So in blood counts in the CBC, you'll typically see some anemia, depending on how long it's been going on. This may just be mild, it may be fairly profound. Certainly in more profound cases, you worry more about MAS, as we'll talk about. Usually there's a very high white count, particularly the neutrophil count. Usually an elevated platelet count, as I said, except in MAS. And as we'll talk about, sometimes a sort of an inappropriately normal platelet count can be an early clue towards emerging MAS. Very high markers of systemic inflammation, CRP or the sed-rate, which is again not SGA specific. And then many of these patients, but certainly not all, have very high ferritin levels. Again, that's more SGA specific, right? If you get a consult on a patient with an unexplained fever with a ferritin over 1,000, certainly moves systemic JIA up on your differential. It doesn't seal the diagnosis. And somewhere around a third of patients with new onset systemic JIA will have a normal ferritin, or just sort of slightly abnormal in the 200 or so range. So a normal ferritin doesn't rule it out. Again, other, quote, rheumatology tests are typically negative, ANA, rheumatoid factor, et cetera. But again, there's no combination of these tests that rules in or rules out systemic JIA. So I'm going to talk a little bit about management of systemic JIA in the last sort of few minutes here. You can kind of think about how we've treated JIA broadly as sort of the pre-biologic era, the early biologic era in the early 2000s with the introduction of TNF like Enbrel, Humira, and Remicade, and then the later biologics around 2010, and then some of the newer drugs that we're moving on to now. With the introductions of the TNFs, as Dr. Weiss, I'm sure, described, we saw dramatic improvements in the outcomes of non-systemic subtypes of JIA. However, TNF agents generally did not have a major impact on the outcome of systemic JIA, with the outcome of some more chronic patients who had really evolved to a polyarticular course. So the answer for that, so the question is why? And really that gets to the heart of SJIA as a very biologically different disease than the other forms of JIA. So as I've already noted, it has less of those typical autoimmune features, right? There's rarely autoantibodies. There's not that striking female predominance that we see in many autoimmune diseases. There's less of a family history of autoimmunity. And in fact, there's almost never been reports of children who have siblings who have systemic JIA. The only ones I know are ones who actually turned out to have a monogenic mimic of systemic JIA. And in contrast, we see these distinct clinical features that really reflect autoinflammation: fever, rashes, neutropenia, very high acute phase response. So what is autoinflammation? So autoinflammation is more diseases with dysfunction of the innate immune system. So if you think about the innate immune responses, if there is an infection or tissue damage, your body's first line of defense recognizes either conserved patterns from potential infectious agents or markers of tissue damage, and leads to this very rapid response of production of inflammatory cytokines, including IL-1, as well as others such as IL-6 and interferons. This leads to recruitment and activation of immune effector cells, and then removal of the infectious agent and resolution of the process. In autoinflammation, what happens is there are inborn error or errors in the innate immune system, such that there's activation of the response by very minor stimuli or a failure to resolve an appropriate activation. This leads to dysregulation of inflammatory cytokines, including IL-1, persistent activation of effector cells, and clinically manifesting as an autoinflammatory disease. And really at the center of that is IL-1. So IL-1 is one of the primary cytokines that drive fever. It drives endothelial responses that can lead to vasculitis as well as rashes. It can drive arthritis. It can drive this bone marrow response of increased neutrophilia as well as thrombocytosis. And then it also very prominently drives IL-6, which drives that acute phase response. This increased CRP, ferritin, serum albumin A, leads to an enlarged liver. But really at the center of this is IL-1. And so our treatment approaches for systemic JIA have been instead targeted towards those more autoinflammatory cytokines. Again, I don't really have the time to get deeply into treatment. I'll note that there are ACR guidelines for the treatment of systemic JIA that were originally from 2011, were briefly updated in 2013 to reflect the FDA approvals of canakinumab and tocilizumab, but are now somewhat dated. There is an update to that that's in the ACR pipeline and will hopefully be coming down in the next couple of years. Probably more helpful for guiding what we really do are the CARA consensus treatment plans for newly diagnosed systemic JIA. Again, these were developed around the same time, but I think reflect what's done in practice. The goal of all the CARA consensus treatment plans are to provide standardized algorithms which can facilitate both clinical care as well as comparative efficacy research. The plans that were proposed originally were for steroids alone, methotrexate with or without steroids, IL-1 blockade with or without steroids, or tocilizumab with or without steroids. In a trial of that was done a few years ago, and then what's happened since then, really those biologic treatment plans have become really the primary approach for most rheumatologists across the country. Systemic JIA, along with the features that we've just described, are associated with several potentially life-threatening complications. One that Peter mentioned is chronic lung disease, which can include interstitial lung disease, alveolar proteinosis, as well as pulmonary arterial hypertension. The other, of course, is MAS, which will transition us nicely here to the next section of talking about this disorder. And I think for this particularly, it's helpful to start with a case to sort of get a feeling for how this can emerge in a patient. So this is a 12-year-old boy. He had presented with 3 days of fever up to 103, as well as a rash and some generalized malaise. He'd been previously diagnosed several weeks ago with systemic JIA, so he has a relatively new onset disease. At that diagnosis, he met the ILAR criteria. He had a polyarticular course. He had daily spiking fevers, including that quotidian fever. He had a classic evanescent rash. He had a little bit of splenomegaly, and he had elevated inflammatory markers. He was started on anakinra, about 2 mg/kg daily, and had initially a very good clinical and laboratory response and was sent home from the hospital. They did note that when he returned later with fever, he did have some sick contacts. Younger brother is in daycare. Again, you can tell this is pre-COVID, when we would just assume that all kids have sick contacts because they're in school from daycare. So 3 days ago, at the onset of the fever, when he first had a fever, he went to the ED, and it's usually what we say to our systemic patients when they have a fever is you probably need to be seen. The ED said he looked great. They got labs, were notable for white count, quite elevated, 23,000 with a neutrophil predominance, CRP of 4.9, ferritin about 1,500, so higher than it had been at discharge. The platelets, 385, I would point out, right? That's a normal platelet count, right? But it's always in a child who's having a high fever, signs of a big acute phase response. When you see a normal platelet count, you should always ask, why is the platelet count also not elevated? So that's sort of a clue that there may be something going on that's suppressing that platelet count. So given some concern for either a flare of his disease or early MAS, he was started on oral steroids, 30 milligrams twice daily, and sent home. 2 days later, he came to clinic because he was continuing to have fever. It was a little bit better, Tmax 101, it continued to just feel kind of not that great. Was a little bit dyspneic during the fevers. Again, looked all right. They thought, let's just bump up the steroids a little bit, sent him home, and got labs. That evening, kind of coincidentally, we got labs, and they called and said that he now expected fever again to 103. And based on both of those developments, we recommended he come back for admission. And so what were those labs? His white count had gone up a little bit. His hemoglobin, sort of borderline low at 12. His platelets had dropped now to about 150,000. His CRP was up a bit, but his ferritin is up quite a bit, to over 13,000. He also had a little bit of an increase in his transaminases. His fibrinogen was 321, which again, in someone who is otherwise well, not a particularly remarkable fibrinogen, but in someone in the setting of systemic inflammation, that's actually a low fibrinogen, right? Because why isn't it higher? He also had a mild increase in his triglycerides. And as we'll talk about in a second, then he would then classify criteria for MAS. So on a mission, he was given 3 days of IV pulse methylpred, given that he wasn't responding already to about 1 per kilo of steroids. He was also started on cyclosporin. He had very relatively prompt resolution of his fevers, improvement in those laboratory markers, and sent home a couple days later on a tapering dose of prednisone. So that's kind of a fairly typical picture of how MAS emerges in a child with known systemic JIA. So what is MAS? So MAS is felt to be caused by excessive activation and proliferation of both T cells, as well as these well-differentiated non-neoplastic macrophages, which can exhibit hemophagocytic activity. And it's those activated macrophages seen in tissue, including bone marrow, liver, lymph nodes, et cetera, that give it its name, which you can see here on the right. And really, MAS is a systemic cytokine storm, and the clinical and laboratory features that you see really reflect that. You see cytopenias, you see liver dysfunction, you can see coagulopathy, and you see this really notable extreme hyperferrotemia. Historically, MAS was said to be fatal in about 10 to 20% of cases. In the large international case collection that led to the classification criteria, they saw a mortality of about 8 to 10%. So MAS in pediatric rheumatology, we can see it in many of our diseases. Lupus, Kawasaki, connective tissue diseases, some of the monogenic autoinflammatory diseases. However, it's most commonly seen by us, at least, in the setting of systemic JIA or adult stills. MAS occurs in anywhere from about 10 to 15% of patients with SJIA in sort of what we call a full-blown or overt MAS. But 10, 20, 30, maybe as much as a third of patients can have more mild or subclinical MAS, where you can see some features of the disease without necessarily meeting those classification criteria or having sort of overt clinical symptoms of MAS. So again, a little bit of history of how we've sort of recognized MAS as part of our diseases. So, you know, going back through the literature, starting in the 1980s, you would see case reports of sort of life-threatening complications in children with what they called systemic juvenile rheumatoid arthritis, which we now recognize as MAS. Acute hemorrhagic manifestations, including DIC, liver failure, neurological manifestations, as well as this notable tissue finding of hemophagocytic macrophages or histiocytes. Notably, it was really rarely reported in those other forms of JIA. And then the phrase macrophage activation syndrome was first actually used by French authors in the early 90s to just really describe those phenomenon when seen in the setting of immunologic or rheumatic diseases. And then in the early 2000s, several authors, including Gram, Ramanan, Angelo Rovelli, proposed that MAS was in fact a form of HLH. So MAS and HLH, or hemophagocytic lymphohistiocytosis. So really, MAS really has striking similarities clinically to HLH. And these here are sort of the 8 cardinal criteria that make up the HLH diagnostic criteria. Fever, hyperferrotemia, splenomegaly, cytopenias, hypertriglyceridemia, and hypofibrinogenemia, the tissue findings of hemophagocytosis, elevated soluble IL-2 receptor, and low or absent NK cell function. So all of those can be seen to degrees in MAS. However, they can often be difficult to tease out from systemic JIA. So fever, right, we see that in active systemic JIA. We can see that in other rheumatic diseases, so it's not really very specific. Hyperferrotemia, similarly, we can see that in active systemic JIA. Cytopenias, as I've mentioned with the platelet count, the degree of cytopenias can really be complicated by the acute phase response in SJIA. You don't necessarily see a sort of an overall leukopenia in MAS. You'll often see lymphopenia, but with sort of a counteracting neutrophilia. And the platelet count, as I mentioned, is being pushed up by the systemic inflammation and being pulled down by the cytokine storm. Ditto for things like fibrinogenemia. And the lower absent NK cell function, you can see that in MAS. It can also be transient in SJIA. Some very nice work from Fabrizio De Benedetti's group showed that the high IL-6 states can lead to transient defects in NK cell function. So those HLH criteria aren't necessarily very helpful for the recognition of MAS. A bit more helpful are the 2016 classification criteria. So these were derived from a large case collection of cases of active SJIA, MAS, as well as MAS mimics. And I should note that these are classification criteria, so they're really designed for research. They're not designed as diagnostic criteria. However, I think they can be helpful in that vein. So what they are, there's several points to it. First, a febrile patient with known or suspected systemic JIA. And then you need to have elevated ferritin. And they picked the very easy and round and easy to remember number of 684. They tried to round it up, but the computer said, no, 684 is the optimal cutoff. Let's stick with that. And then at least 2 of the following 4 laboratory variables. And they really wanted to pick ones that were easy to get in an ER, right? You know, you can have somebody go to the community ER, get basic labs, you'll have those results within a couple hours. You don't have to send soluble IL-2 receptor to Cincinnati. You don't have to do a bone marrow biopsy. You don't have to do NK cell cytometry. You can do this easily. So a platelet count of less than 181, transaminases elevated, triglycerides elevated, and a fibrinogen that's less than 360. And again, notably, right, a platelet count of 181 and a fibrinogen of 360 in a patient who's not having acute inflammation, those are actually normal values. But again, this is a febrile systemic JIA patient. So they're in a state of systemic inflammation. So values at that level are inappropriately low. And so if we go back to our prior case, they satisfy all 4 of these criteria. So as I said, systemic JIA is considered as a form of HLH, one of the secondary or reactive forms of HLH. The nomenclature in this field is frankly a bit of a mess, and often can really hinder our communication with some of our other colleagues. So, you know, it can be considered as a number of things. So secondary HLH, the new Histiocyte Society defines that as, quote, apparently non-Mendelian HLH, generally occurring later in life, but not infants, usually less severe or persistent than the primary or familial HLH. And there's usually a trigger, right, or a known or suspected trigger, whether that is an infection or malignancy. And then the Histiocyte Society is then called what we call MAS. They call it MAS HLH. So secondary HLH with a rheumatic disease as a trigger. I always joke that this is secondary HLH when diagnosed by a rheumatologist, whether or not there is a rheumatologic disease as the trigger. And then you're going to increasingly see the phrase of cytokine release syndrome thrown about. This, strictly speaking, is a secondary HLH that's triggered by things like CAR T therapy or other chemotherapy. I sometimes say this is just secondary HLH when diagnosed by an oncologist. And then you have the broad term of cytokine storm syndrome, which is, you know, the broad advantage is it encompasses all of these things that we're talking about. The downside, of course, is it's not very specific. It doesn't really tell us what we're talking about from a pathogenic level. So just a little bit about the pathogenesis of MAS, which can give a little bit of hint of how this is different from some of those other forms of HLH. And really the key to that is IL-18. So what's IL-18? IL-18 is an IL-1 family cytokine that's produced by some inflammasomes from antigen-presenting cells. You can see it here on the left, which then amplifies innate immune signaling, and particularly amplifies interferon gamma production from CD8s as well as NK cells. And notably, interferon gamma is really felt to be one of the key drivers of the pathogenesis of familial HLH. So it's been proposed that those very high serum levels of IL-18 can distinguish, sorry, that slide looks to run on its own for reasons that are unclear, can really distinguish SJIA patients that are at risk for MAS. And this was really spotlighted very nicely by the work from Scott Canna and others when they identified patients with monogenic NLRC4 gain-of-function mutations. Those children have really persistent elevations of IL-18 and recurrent episodes of MAS. So as I mentioned, high IL-18 really distinguishes systemic JIA, but even more so may distinguish those patients with SJIA who are at risk for development of MAS. So this was very nice work a few years ago by Makasi Shimzo, where they really plotted IL-18 versus IL-6 and could really distinguish two groups of systemic JIA patients. Those on the lower right-hand part of the graph in the light and the dark green had high IL-18 relative to the IL-6. And those had a high risk for MAS. So all of the patients in the dark color are patients who had episodes of MAS, and all of them are sort of below that dashed line in the middle. On the flip side, those with a lower ratio, who had really an IL-6 predominant, were older, had more arthritis, and notably had no episodes of MAS. Possibly a more helpful way to think about this relationship is to think about IL-18 as a function of the interferon gamma activity in a patient. Interferon gamma itself is tricky to detect. It really likes to stay in the tissue. So a much better surrogate marker for interferon gamma is an interferon-induced chemokine called CXCL9. So this is work from Scott Canna that came out about a couple years ago now. The top graph, this is the total IL-18. So very high in systemic JIA, very high in kids with MAS, also high in forms of HLH, infection-associated as well as familial HLH. CXCL9, or the interferon activity, highest in these forms of MAS HLH, not really elevated in patients with systemic JIA without MAS. However, if you take the ratio, you find something much more striking. The ratio of IL-18 to CXCL9 in systemic JIA and MAS is very elevated, even more so in MAS, but higher in both states. Whereas in other forms of HLH, familial HLH and infection-associated HLH, you see high IL-18, but it's really balanced to the level of interferon activity. Whereas in SJIA and MAS, you see this preponderance of IL-18. And so I think that can be helpful in trying to determine whether a patient has MAS or a more genetic form of HLH or an infection-associated HLH. Treatments, again, don't really have time to get much into treatment. This figure is from a review from Gram, Anna Karen Horn, and Fabrizio De Benedetti, which is very nice. But I think sort of shows in the pathogenesis of MAS where we target treatment. So many of our treatments are all the way to the right there. They're targeting that cytokine storm, this activation loop of macrophages producing pro-inflammatory cytokines that are driving interferon production from lymphocytes that are driving pro-inflammatory cytokines in this sort of vicious circle. So this can be steroids, this can be T-cell targeting agents like cyclosporin, this can be corticosteroids. There are clinical trials ongoing for direct targeting of interferon gamma. In many kids with MAS, it's and there's an infectious trigger, and sometimes there are specific agents that you can use to target that. Fungal bacterial infections, treating those directly. Viral infections, if there's an antiviral. EBV infection, we've had very good success using rituximab to target those B cells as a reservoir of EBV that's sustaining that infection. And then often this emerges in a disease flare or in sort of high background inflammatory activity. And I think this is the role for anakinra in trying to treat that background autoinflammation as a driver of MAS. And then finally, in some patients who have recurrent MAS, we really can never wean steroids and are really probably, some sort of a flavor of a genetic disease. Treating that with a bone marrow transplant is potentially an option. We've had 2 or 3 patients in my time at Cincinnati who've actually had to go to bone marrow transplant for really recurrent MAS in the setting of a systemic GIA-like disease. All right, so then for the last 10 to 12 minutes, we're going to shift gears a little bit and talk about something that's kind of the same but different, which is MIS-C as associated with SARS-CoV-2. So as the initial wave of acute COVID sort of peaked in the States and in Europe in the last couple months, we were very reassured that we saw what they saw in China, which was that only rare serious infections were seen in kids. Many kids had asymptomatic disease or a very mild URI. Relatively low numbers of kids in the hospital with moderate to severe illness, which we're very happy to see. However, then in mid-April, we began hearing reports, first out of the UK and Italy, and then out of the East Coast of the US, of kind of a bizarre illness where previously healthy kids would present with systemic inflammation, fevers, some features of Kawasaki, but a very shock-like presentation. And initially questions of like, this is kind of weird. Has anyone seen this? Until realizing that we're actually seeing a real surge of these cases. And it's since had many names. Again, those initial kind of questions that people asked, people nicknamed this Kawa COVID or Kawasaki. The British, who were the first to make sort of a national alert to this, called this the Pediatric Multisystem Inflammatory Syndrome, or PMIS. They then switched the I and the M to call it PIMS, which I think is just because it's the summer, and in Britain you drink PIMS, that's what you drink. However, in the US, the CDC released an alert in May, and they've settled on the name of MISC, Multi-Organ Inflammatory Syndrome in Children. And that has since been the name that we've mostly settled on using in the States. This is the CDC case definition for MISC. There are several parts of this, so we'll walk through it quickly here. So an individual aged 21 or younger, so a child, check. Laboratory evidence of inflammation, and they give several that can include CRP ceterate, fibrinogen, procal, ferritin, IL-6, so defined quite broadly. Clinically severe illness requiring hospitalization, and multisystem, so more than 2 organ involvements: cardiac, renal, respiratory, hematologic, GI, dermatologic, and neurological. And of course, the required no alternative plausible diagnoses, and then some association with COVID-19. So positive PCR, serology, or a exposure, so known exposure within 4 weeks of the onset of symptoms. And in areas where they've really seen epidemic spread of that, they've really considered basically everybody in the community to have had possible exposure. So since May 2020, there's really been an explosion of case series that have described this condition from, as I said, initially UK, Italy, Europe, France, and Switzerland, now several in the US. And you can see the numbers of patients here, as well as the phenotypes that they're reporting. Hyperinflammatory shock resembling Kawasaki, toxic shock syndrome, acute cardiogenic shock, systemic inflammation, and then this sort of Kawasaki-like Kawa-COVID syndrome. I'm really going to focus on one of these papers to kind of give a picture for what we're seeing. This is first from the CDC, from their recent paper in the New England Journal, where they showed the distribution of cases that have been reported to them. Again, most in those sort of tier 1, wave 1 states: New York, New Jersey, Connecticut, Massachusetts, Michigan, but increasing numbers in sort of the heartland and the states with lower burden of first wave of COVID-19. So this JAMA paper, I think, is very, very nice because it really breaks up the phenotypes that they see in MISC, which again, this is a British paper, so they're calling it PIMS. So this series included 58 children from 8 hospitals in England, including those initial 8 that were reported, diagnosed based on really any of those criteria, the WHO criteria, the British criteria, or the CDC criteria, which are largely overlapping. And they also compared those to a large San Diego cohort of Kawasaki to kind of look at how it was the same and different from Kawasaki. And they really identified 3 phenotypes, and this is really in line with what we've been seeing here as well. There's a group with shock. So probably about half of these kids have cardiogenic shock requiring inotropes or fluid resuscitation. Then there's a large chunk of patients that meet Kawasaki criteria. Some of those are likely ones who would have just had Kawasaki normally. They just happened to have it in the time of COVID, so they got labeled with this fancy new disease. But others are a little bit different. Anywhere between 10 and 20% of the cases here. 12% sort of met criteria for KD. An additional several children didn't meet criteria but had an aneurysm. And those overlapped a little bit with those with shock. And then there are those who sort of didn't have shock, didn't meet Kawasaki criteria, just had fever and signs of systemic inflammation, and that's about 40% of the cases reported in this series. So, given this sort of strong connection to Kawasaki disease, what just remind ourselves what Kawasaki is and what these features are, right? So Kawasaki is a self-limited vasculitis of unknown etiology. Its incidence in the US is about 10 to 40 per 100,000, higher in East Asian ethnicities. In Japan, the incidence is about tenfold higher. The AHA criteria are fever plus 4 of those 5 of those cardinal clinical criteria, which is that conjunctivitis, swelling of the hands and feet, rash, mucositis, and large adenopathy. And then there's incomplete Kawasaki entity, which is fever plus 2 or 3 of those clinical criteria, plus classic lab changes. And really those classic lab changes reflect the degree of systemic inflammation and cytokine storm. So, the question that we were all asking when these cases were first being reported is MISC just more and worse Kawasaki? And a very nice kind of retort to this question was provided by Stan Schulman from Northwestern, who's really one of the Kawasaki experts, who gives it an emphatic no, it's not just more and worse Kawasaki. This is something different. And several reasons for this. One is the demographics. As I mentioned, Kawasaki, 50% of them are under 2, and really the sickest Kawasaki are the infants. 80% of them are under 5. Highest attack rates in Japan, China, other Asian countries. In the US, the mean age, and as well as in Europe, the mean age of MISC is about 8 to 10. And there's some hint that there's children of sort of African ethnicities or Latino ethnicities may be more common, although that's hard to disentangle with what we know about just the epidemiology of acute COVID infection. But they're certainly not seeing higher rates of it in children of Asian ancestry. Another is the clinical features. Children with MISC almost universally, 80% plus, have very frequent and impressive abdominal pain, diarrhea, and vomiting. There's actually an early case series before people started naming this of children and young children who presented with acute abdomen and got roulette appies for systemic inflammation associated with COVID-19. Multisystem involvement. And relatively few of these patients have classic Kawasaki criteria, right? 10 to 15% really only meeting those 4 out of 5 Kawasaki criteria. And then particularly those cardiac features, right? We're like, okay, inflammation in the heart, it sounds like Kawasaki. It's true. Kawasaki, however, the hallmark, remember, is these coronary artery aneurysms. Myocardial involvement is rare. Shock is certainly reported in Kawasaki shock, but not common. MISC, however, again, nearly half of these patients presenting with shock, anywhere from moderate to very severe myocardial involvement. And aneurysms are reported, but are uncommon. And then finally, the laboratory features. The laboratory features of MISC have a much stronger resemblance to MAS. You see this very high ferritin, very high D-dimers, very high triglycerides, as well as what's been reported about sort of the late hyperinflammatory stage of COVID-19 in adults, where you see this leukocytosis with neutrophilia, lymphopenia, thrombocytopenia, extremely high CRPs, and you see those inflammatory features are much higher in MISC than you see in Kawasaki, and the JAMA paper really lays that case out very nicely using Jane Burns's large database. So this is a very nice figure from the Italian report of what we now call MISC, where they've plotted here in those blue bars the number of patients who presented to their ER for symptoms consistent with COVID-19, acute COVID-19, and then those asterisks that you start seeing about halfway through the graph are where the patients in the initial cohort of 10 with MISC. And you can see there's about a 4 to 6 week lag from that peak of COVID to when they start seeing those MISC cases. And that's in relative agreement with what the JAMA and the New England Journal paper have said. Their patients who had acute symptoms of coronavirus were a mean of about 25 days from those until the onset of MISC symptoms. What do we do about MISC? So the ACR has recently put together some clinical guidance on children with MISC. This was developed by a task force they've put together based around this, as well as COVID-related hyperinflammation in children. It was composed of 9 pediatric rheumatologists, including myself, along with adult rheumatologists, peds cardiologists, and ID and critical care doctors. We were divided into subgroups where we generated a preliminary statements as well as an evidence report, which were then refined through a consensus process built around a modified Delphi process. And this was led, the overall process was led by Jay Mehta, who's the chair of the ACR Peds Rheumatology Committee, and the MISC guidelines were led by Lauren Henderson at Boston Children's Hospital and Harvard Medical School. So a couple of key things I want to highlight from this. This whole document is very helpful, and I would encourage you to read it. It's just a couple of pages. This is a flow chart from this, which kind of goes through an initial approach to thinking of when you should think about MISC. So we start with this box here. Does the child have these symptoms, right? So somebody who has a fever, who has potentially an epidemiological link to COVID-19, which includes being in an area with high prevalence of COVID-19, and then suggestive clinical features, including rash, GI symptoms, swelling of the hands and feet, some of these other Kawasaki criteria. If it's no, continue to monitor. If it's yes, then doing some investigation for MISC. And if the child looks well and is not having shock, this can be done in sort of a tiered approach. Kids who are sicker, I think, need it sort of all immediately to sort of quickly determine whether they need treatment. Sort of an initial evaluation for are there features of this sort of systemic cytokine storm, CBC, CMP, SED rate CRP, as well as sending COVID-19 serology and PCR. Then, are those results then consistent with MISC, with an elevated SED rate and or CRP, and then some of these other labs that are suggestive of that cytokine storm: lymphopenia, thrombocytopenia, hyponatremia, neutrophilia, hypoalbuminemia. And if yes, then sending this sort of full evaluation to look for some of the end organ disease that we see in MISC, particularly the cardiac disease, BMP troponins, other signs of inflammation. Notably, almost all of those patients in the JAMA study, regardless of whether they had shock, had some elevation in the BMP and troponin T, suggesting at least some myocardial dysfunction, even if they didn't have clinically overt myocardial dysfunction or shock. A couple other key statements from these guidelines, and again, I would encourage everyone to read this sort of short document. One is that children who are being investigated for MISC should be investigated for other infectious and non-infectious etiologies, right? Every kid who shows up to the ER with a fever and a CRP shouldn't be getting IVIG and steroids without sort of a careful assessment for what they might have. Again, patients without those life-threatening manifestations should really undergo a full diagnostic evaluation prior to that immunomodulatory treatment. Patients who have shock, significant respiratory distress, neurological changes, or features that are concerning for Kawasaki should be admitted for observation and potentially treatment for standard of care. And finally, we really recommend this to be a multidisciplinary team, including pediatric rheumatologists who are very familiar with these kinds of treatment approaches, cardiologists, given the rapidly progressive cardiogenic shock that's seen, infectious disease specialists, and hematologists, as well as other specialists as needed. And I believe that I'm at my stopping point and not too far over the time. So again, our objectives here at the beginning, and I'd be happy to talk about any questions that have come up or any of these other areas as well.
Thanks, Dr. Schulert. That was a fantastic talk. I think you really did have a tall order in covering all these topics. Time allotted, and I think you did a really nice job. There were a variety of questions that came in the Q&A, mostly related so far to systemic GIA and MAS, so I can those. The first was, do you always check HLA-B27 even for patients with a clear systemic GIA diagnosis?
Yeah, that's a great question. You know, B27 is really controversial about people who check it. I frankly only check it in patients where I'm concerned about sort of an ERA type disease, because I think there's a little bit of evidence that patients who have sort of ERA and B27 positive are more likely to have that axial involvement. And I get screening, you know, MRIs of the SI joint. much quicker and more regularly in those patients. Whereas in those where I really don't suspect an enthesitis-related arthritis, I really don't, because it doesn't change my management, right? It's not, you can have, if they look like a systemic and smell like a systemic, a B27 isn't going to change my treatment approach. And the lack of it isn't going to, if I think this is an ERA, the lack of it isn't going to say, well, it's not ERA if they have enthesitis and arthritis, for example. So yeah, it's on there, but I almost never get it, frankly.
Awesome. We had another question about identifying the rash in patients with dark skin. Any tips on how that might look?
I agree that is challenging. I find that then the parents' report is incredibly helpful because they know their kids. They've looked at their kids' skin every day of their life, and they are much more likely to be recognizing something that's very subtle. Again, giving them sort of the clues of looking in, looking through the armpits of areas of contact. As well as sort of yourself seeing if they have a Kobler phenomenon on exam, and particularly when they're being febrile and inflamed, can be very helpful. But I agree, that's challenging.
Yeah, I'll just add my own anecdote. I think as a rheumatology fellow, I've learned to really go and do my best to actually do that exam while the patient is having a fever. And I've seen it a variety of times where others have missed it because it really can be subtle.
Yeah, I agree. And of course, it's always like right when you're trying to go home for the day when they spike a fever. So,
a question about the case that you presented. Was there a reason that patient was not initially given pulse steroids?
When they first presented with sort of the fever and increased labs, at that point, I think because they were clinically well and their labs weren't sort of super concerning and they're already on anakinra, the decision was made to try to treat them as an outpatient. It's interesting that in my experience, especially in patients who are on biologics, who have sort of an MAS that's triggered possibly by a viral infection, especially if you catch it early, they don't necessarily have to be admitted for pulse steroids. They can sometimes be treated with just some oral high-dose steroids, but then they need very close follow-up, as it was seen in there. They need to be seen again in a couple days. Again, that was a child who lived a couple hours away, didn't really have a community hospital that we could easily partner with. They looked great, so we said, cool, take some steroids, come down to Cincinnati and see us in a couple days, and at that point, we'll decide what to do.
Excellent. A couple.
Can I ask Chris briefly, would you have considered going up on the anakinra? So 2 per kilo is not a big dose.
Yeah, I would. I probably would have as well. I think that's certainly an option. And I think that's what we see. I think a lot of the initial controversy about whether anakinra helps for MAS comes from the fact that we just weren't using enough of it, right? And so some of the initial anakinra series is when they were using like 1 to 2 per kilo and they had MAS, and they said, oh, anakinra causes MAS. And like, well, anakinra doesn't cause MAS. It may not be enough to treat it in every case, and it's certainly not enough to prevent it, especially when there's an infection that can trigger it. But yeah, I think another approach would have been to say, well, let's double the anakinra, or if they hadn't been on the full syringe, definitely go to the full syringe.
Couple of other questions related to cytokine blocking therapies. So for the MAS patient, was tocilizumab considered? And if so, what was the reason for not changing his medication?
Mm-hmm, mm-hmm. Yeah, that's a great question. And there's kind of a couple pieces to that. So there's not a whole lot of data about tocilizumab for acute MAS. It's being increasingly used more since the sort of cytokine release syndrome story has sort of percolated. And tocilizumab is actually approved for treatment of cytokine release syndrome. I certainly have colleagues, non-rheumatology colleagues, who, and somebody with sort of MAS, HLH-like disease, they give tocilizumab. Tocilizumab is a great drug for treating fever and treating CRP. And so they'll give a dose of tocilizumab, fever will go away, CRP will go down, pat themselves on the back and declare victory. But then I find sort of a couple days later, the symptoms sort of rebound. And it works great in cytokine release syndrome because there's a very self-limited trigger, this infusion of CAR Ts. And you just have to ride out that cytokine storm and they're going to be great. So for that, Toci is a great option, right? For MAS, I don't think it's quite as good. And there's certainly not as much data as there is for something like anakinra. As far as whether we would change that child, from an IL-1 blocker to an IL-6 blocker. In that case, the suspicion was that there was an infection that triggered that. If we didn't have a good story for an infection triggered, we thought they were just failing, and they had sort of a MAS episode triggered by a flare, then I think absolutely you gotta then reassess and try something different, whether it is a different IL-1 blocker or a different dose or changing to an IL-6 blocker. But in that particular one, the thought was this was just a viral infection that triggered this episode.
Great. Along the same lines, there was a question, do you look at serum cytokine levels to sort of help you decide which
Yeah, that's a great question. I generally don't. And I mean, again, I'm in a place where we can get those pretty easily, right? Many of you guys probably send your serum cytokine panels to us. Again, I don't get the results any quicker, unfortunately, even though I've got the lab manager on speed dial. It still takes me several days to get them. So the turnaround time is certainly a limiter to that. However, it's not been very helpful looking at cytokine levels to help drive treatment decisions, with the exception of those proxies for interferon activity, such as CXCL9. I think that can be very helpful when you're worried, is this just a flare of systemic JIA or is this emerging MAS? A paper that we published a few years ago with Fabrizio Benedetti's group and Claudia Bercalia from Roma showed that in patients who have very active systemic JIA but without MAS, you don't see any elevation in CXCL9. But when you have MAS features, you see a very striking elevation in that. So that can be very helpful in that early recognition of MAS, if you can get it. Again, we run it here, again, still on a weekly basis, so it takes a little longer to come around. So it's more, again, in retrospect, and you have to be driven by your clinical suspicion. But I think that's one place if you can get the result quickly where the cytokine level can help. I should note that's not on our cytokine panel. It's a separate test that we run. Probably should be on our cytokine panel. I'll talk to them about that. But
Right. This is a question of mine. I know that this goes a little beyond the scope of what you talked about, but you did mention the lung disease associated with systemic JIA, which I think is a fascinating and scary problem.
Yeah.
You didn't really discuss, but it seems to be a newer feature of systemic JIA described really coinciding somewhat with the emergence of biologic therapies. We had an amazing rheumatology nurse care coordinator who retired last year, but who was with us for about 25 years. And she posed the question to me kind of as she was leaving, is this maybe this lung disease, could it be a feature of just these children being treated with less steroids than they were in the past? Is there something that steroids in particular were better at suppressing in terms of inflammation?
Yeah. So I think that the question of what has caused this increase in lung disease is really unclear and likely has multiple factors. And I think certainly one of those candidates is less steroids, particularly as treatment of ILD. The mainstay of that is steroids, and it could be that biologics in the setting of steroids are something that is less of a risk than biologics on their own. It's really very very murky to me, because I've seen patients who have developed lung disease on really any combination of treatments you could think of, and patients who've recovered from or improved from their lung disease while being stable on a number of different biologics as well. So the etiological role of treatments in this is something that is really actively being explored and really quite confusing, to be frank, even to me.
Awesome. Just to switch gears a little bit here to MIS-C, there's a question of, in the adult literature, there's a lot of use of dexamethasone at this point. Why is this not as prevalent?
Yeah. So you mean, I guess the question is whether that's for just hyperinflammation associated with COVID-19 in children broadly, or specifically in MIS-C. So again, in the guidelines, one of the parts that we talk about is basically sick acute COVID-19 from hyperinflammation. And interestingly, we finalized that like a couple days before those preliminary results for dexamethasone had come out. And so we sort of wrestled with the question of steroids, and I think we settled on sort of consider steroids. I think if we were to be doing that now, we might say something more strongly about that. And our own internal guidance at Children's would be that for somebody with acute COVID-19 and features of hyperinflammation, to strongly consider Decadron, and I would encourage Decadron. For treatment of MISC, we're at with the what's become the standard of care and is in the guidance as well is IVIG plus steroids, and steroids at a fairly equivalent dosage, probably to what the COVID Decadron is. So I think that they definitely have a role in hyperinflammation associated with COVID-19, whether it's acutely or post-infectious.
Great. I think we may just have time for one more quick question if possible. It's not entirely clear to me which vein we were talking about here, but I'm guessing systemic GIA MAS. What is your threshold for imaging, for example, to rule out something like a neuroblastoma?
I think for newly diagnosed patients, whether it's, whether you're worried about systemic GIA or MIS-C, and actually some of these MIS-C kids, systemic GIA is on the differential. I feel like especially if there's not arthritis, the kids who don't have arthritis, I think they need imaging before you can say that this is systemic GIA, and they need a bone marrow biopsy and they need imaging. If they don't have arthritis, if they really strictly meet those ILAC criteria, they have arthritis, they have a classic fever, they have a classic rash, they have classic labs. I don't think they necessarily need imaging or necessarily need a bone marrow biopsy, but those who don't have those classic features absolutely do. And if the question had been about MASC, again, I think in patients who don't have shock, you have the time to be able to carefully evaluate your differential for other things that can cause fever and multi-organ system involvement. And that's why we recommend a multidisciplinary team that's in the evaluation of these kids. I've heard from colleagues all over the country about various diseases, atypical infections, malignancies, rheumatic diseases, that initially people were like, oh, this is MIS-C, we gotta give them IVIG. And then once they actually take a look at the child, they realize that it's not that. And often are something where just slamming them with steroids would have been detrimental.
Excellent. Robin, I think we're wrapped up on time right now. Is that correct? Or there is one additional question here?
We can do one more.
Okay. This question was about CXCL9 and whether you looked in MISC.
That's a great question. We are looking at that in MISC. The ones that we've run it on so far it's been high, but like in those other forms of HLH, it's been sort of balanced with the IL-18. So IL-18 a little bit high, and I asked Mark Gorlick at New York, who has probably seen more MISC than anybody in the US. And he said in the ones where they have checked things like IL-18, they see, again, a little bit of an elevation, but not nearly what you see in something like systemic GIA or MAS. Okay.
So maybe we'll close the session there. So Grant, thank you for a fantastic talk.
Thank you.
Superbly clear, superbly useful, and a great question and answer session.
Yeah.
Thank you all for participating. We had over 50 participants, which is really exciting to spread the message. So I hope you'll all participate in other VIP pediatric seminars coming forward. Take care. Bye-bye.
Thanks, guys.